Good evening, everyone, and welcome to Getting Ready for the Maryland Primary Care Program. Access and continuity is the topic for tonight. Glad that you all could join us. I'm Dr. Howard Haft. I'm the Executive Director of the Program Management Office for the Maryland Primary Care Program. In tonight's webinar, we're going to cover two broad topics. One is access and continuity is one of the key elements of advanced practice transformation. And we'll also spend some considerable time going over some of the nuts and bolts details of the program, things that will be required as we move forward over the next several months in terms of documents to execute and some timelines. And then finally finish up with adequate time for questions and answers at the end of the presentation. So first I wanted to spend a few minutes just talking about access and continuity. This is really one of the foundational important pieces of any primary care practice, as I'm sure you already know. And this really is a trusting and continuous relationship between the patients, their caregivers, the team of professionals who provide care for the patients, and really is the effective foundation for primary care. And for most of our practices, most of the people who are entering the program, this has already been a fundamental issue that you've been providing. But I just wanted to highlight some of the particular areas that we like to emphasize in the program, and at the end answer any questions you might have. And it really is a very simple process to assure that your patients have both access and continuity. First is going to be the ability to ensure that the patients have just simply access to a care team that they know about. And then enhancing that patient and provider relationship and increase the likelihood that patients will get the right care at the right time for every patient. And ultimately, this will lead to the ability for patients to achieve the care that they need in the best possible venue, so the patients can avoid unnecessarily having to go to places other than their trusted provider, have to unnecessarily go to an emergency department, or unnecessarily have to be admitted to a hospital when they can get much better care from their primary care providers. So first part of this is empanelment for continuity. Empanelment simply means the ability to allow your practice management system in health IT to produce, in fact, a bona fide roster that assigns each patient to a care team or a practitioner, and to be able to sort and review those patients by assignment. And the assigned provider should be able to be visible in the patient record, so that other people in the practice know who the patient essentially belongs to. This sounds simple, but it is really important, and particularly in the current environment, patients really want to be able to know who their doctor is, who their care team is, who their ancillary providers are, so that they can develop a trusting relationship with those individuals. This is different from the relationship that happens in a wide open clinic where people come in urgent care others and they see a different person every time. That's great for care, but it doesn't develop longitudinal relationships that our patients want and that we want to have with our patients. We really want to make sure that our providers and the care teams that they lead have identified essentially the flock that they are going to be responsible for. And they know who they are, and they know what their needs are, and likewise the patients know who their care team is. This is really essential to providing that continuity of care. And then empanelment is this process where we make that happen through health IT. And the goal here is that we would achieve and maintain at least 95% empanelment to a practitioner or care team in the program. And then allow that to ensure that patients have 24/7 access to the care team or practitioner with real-time, and that somebody in that care team has real-time access to the EHR. Of course, you can't be available to you individually 24 hours a day, 7 days a week, but whoever you sign out to, that they would have that access to the records of that patient, and that patients would know that they're by extension a part of the care team, and that they're acting on behalf of the care team for the patient in off hours. And that the practice is organized care teams by practice identified teams that have specific and identifiable panels of patients to optimize that continuity. So however the practice works, so certainly if it's a one-person practice, it's easy to do. If it's two, then dividing them up between two providers. And some larger practices divided up into teams. Each practice will be different depending on their size and configuration. But again, the important thing here is that that there's an organization around teams and that the patients understand that organization. Empanelment also allows us, again through Health IT, to identify who the active patients are. And active patients are usually those patients that are attributed to the team and to the provider who have been seen by a look-back period of about 18 months or so. Some can do it longer than that, but at least a minimum of 18 months. This also allows you to identify those patients who may be on that active roster but have not been seen for 6 months or a year, and are in the metaphor of tending your flock, or the sheep who have wandered away and need to be brought back in and seen again. This is an extraordinarily powerful piece of Health IT that allows you to do that. And then linking in and paneling each patient to a practitioner or care team. Again, this is assigning each active patient to a care team. And this care team could be a variety of different things. They could be a clinician-driven care team with a physician, a nurse practitioner, PA, or others, or it can be a larger care pod in larger practices that might include the physician, advanced nurse practitioners, the physician's assistants, medical assistants, licensed clinical social workers, and others, and larger team. However that's configured, it's important that the patients understand that that's the configuration, so they can relate to that and they can adjust to that kind of team approach to care. This also very much allows those at the top, whether it's a physician or a nurse practitioner, to be the captain of the ship and be able to delegate responsibilities to others, and then the team understands that they're working under those delegations, and the patients understand that they're seeing people who are under those delegations also. Then it's secondarily, besides the continuity, it's allowing access to care, and this is certainly one of the key issues that has been notable recently in the press, and that I think we've all felt also, that it's sometimes very difficult to get to see all the patients that you need to see in any given day, and the demand may be greater than the resource available. But we hope to be able to use tools to make sure that patients can get timely access to care by providing 24/7 access guided by the medical record to advice and information that can guide the patients to care with perhaps not even being seen in the office at the time, using patient portals to secure messaging to provide health information to patients, providing extended office hours. Often it's difficult for patients to take a day off from work and come in the middle of the day, where it's more convenient for them to come in either on the way to work or after work in extended hours, and adjusting provider schedules accordingly to allow some of those flexible times is often very beneficial to the patients, and can be easily conformed for most practices. Providing same-day or next-day access to patients with that same patient's care team is also important, and sometimes that's just a matter of configuring schedules so that there's always a sufficient number of same-day or next-day appointments in the schedules that are left open. And then as the practices mature and go to more advanced primary care, being able to provide alternative care outside of the traditional office visits to increase access to care, group visits, phone visits, home visits, telemedicine, other kinds of things that, particularly in the capitated or partially capitated environment, are much more available alternatives for practices to provide those kinds of access to patients. In the end, really the goal is to make sure that our patients, all of them, can be seen in a timely fashion, depending on what their needs are, and satisfying the majority of their needs to be cared for. So the next section, this is repetitive of what we will go through probably with all of the subsequent webinars also, just remembering why we do this, why we do access and continuity. And it's clearly to provide the best quality of healthcare for all Marylanders, And in many ways to free our primary care providers from the need to have ever increasing volumes. Providing access doesn't mean necessarily having to see more patients every day. It's just doing a better framing of how you see patients and offering alternatives to the typical volume-loaded schedule. Reducing the barriers for this is not part of necessary access and continuity, but one of the things we always want to do is reduce the burden of various quality reporting requirements, and ultimately to avoid our patients unnecessarily having to go to emergency departments and hospital visits when they are much better seen and cared for in our primary care offices. Benefits to our patients continue to be the freedom of choice for patients, particularly for the Medicare fee-for-service beneficiaries. They are free to see anyone that they want. There is no additional copayment when they're seeing patients in this program and achieving and being afforded of all the additional resources that are provided under the program, but they're still free to see anyone they want. And certainly if they have better access to a different provider, they may choose to see other providers. It's really important for the patients, again, to know that they have a team led by their doctor. This is the empanelment issue, with expanded hours for the patients, alternative flexible care options, records that are available across the continuum, care managers in our practices that they may not have in other practices, and that's a significant benefit within the Maryland primary care program. Medication management support at an enhanced level, the ability to link to community and social supports, and practices having behavioral health co-located or embedded in their practices. And then for our providers, as we provide more and better care and our patients are more satisfied by that care, our providers are also more satisfied as we see their health status of the beneficiaries and all of our patients improving in a measurable way, as we know that we can deliver care based on need and not on volume, that we can provide care management supports, and that we'll have people who can, in our offices, who can lean in and provide that extra support for those patients who are most in need, and it will not all devolve to the efforts directly of the provider, but things that the provider are directing care managers to do. And then it's supported by prospective and financial incentives. At the end of the day, the provider should be compensated better. So just to review again, the payment incentives that are within the program that support the access and continuity and all the other pieces are the care management fees, which are significant and are given in a prospective way in advance every quarter, and allow the practices to hire care management personnel and allow them to extend additional staff for manning phone lines and in additional hours, and allow them to do more in terms of group visits and telehealth and all of those other things that without additional funding would probably be challenging to the practices. They also are provided with performance-based incentive payments that are also paid in advance on an annual basis that allow practices to really focus on improving patient satisfaction and quality measures that they're able to focus on and see how they're doing as they go along. And then in track 2, the comprehensive primary care payments, which are partial capitation, and allow even more flexibility in terms of the provision of care. In addition, there's a reminder again that many practices have chosen care transformation organizations, and they will be providing additional resources with care managers, pharmacists, LCSWs, community health workers to support all of these services: care coordination, care transitions, data analytics, screening, and assistance with meeting all of the care transformation requirements. And they will be specifically focused on assisting practices in achieving all those goals, and specifically on access to care and continuity. And the CTOs will provide services that are integral to meeting the care transformation requirements, but don't require the personal professional services of a physician. These services are provided incident to and under the general supervision of the provider or at the practice. And they enhance the capacity of the practice to provide care management services, improve workflows, and manage the populations. And they provide resources that are embedded at the request of the practice to serve patients both in the practice and in the community. Now I think that's the clinical piece of this. There's quite a lot of work that we'll all need to do over the next several months in terms of the process leading up to the start date of January 1st. And there's some documents that are very important that will need to be completed. And we want to bring your attention to the timeline and give you some, what I think will be helpful tips on completion of those documents. I'll point out now and then point out again at the end of the webinar that there has been an overwhelmingly positive response to this program with hundreds and hundreds and hundreds of practices applying. And we're so happy to see that enthusiastic response. But it has created some technical issues, particularly in getting some of the documents out from our partners at the Center for Medicare and Medicaid Innovation. They're working very hard to get documents out on time, but there may be some technical issues that arise. If you do find technical issues or delays in getting documents on your end, please let them know through their inbox, and they will be responsive. And we'll continue to work with you and with them to make sure that we get this period of document production completed in a timely fashion. And now I'd like to turn it over to my colleague, Alice Sawinski-Rice, who will walk us through the timeline and through some helpful tips on document completion. And at the end, we'll have some time for questions and answers. Thank you very much.
Thank you, Dr. Hast. So I'm going to talk us through the timeline just to, once again, level set on what's coming up now and through the end of the year. So you've probably seen this slide before. It has the major milestones going from now through January 1st. The milestones that apply to practices are in red, and the ones that apply to CTOs are here in green. So as Dr. Hast mentioned, in the next few days, leading into early next week, practices should be getting some information emailed out from CMS. It is the first week in October, so that is the timeline that we would expect for that. A few weeks afterwards, once practices have returned some of the information that CMS is requesting, CTOs are going to get additional information about which practices have partnered with them. In early November, the state's going to release the CTO practice arrangements, and those are documents that are going to define the relationship between you as the practice and your CTO if you're partnering with one. Also, in early November, CTOs are going to get their participation agreements to sign with CMS. Then moving into early December, practices will get their participation agreements along with a second letter that's going to include some more onboarding materials that you'll need to turn in before the end of the year. I just want to emphasize here that December 21st is the final deadline to get all your documents in. And this is important because if you don't have them in by that deadline, you're not going to be able to start the program in January. So that's actually a nice segue into the first bullet on this slide, and that's please make sure that you have the CMS email address added to your Safe Senders list. We've already gotten a little bit of feedback that some practices aren't necessarily receiving everything that's been sent out because things are going to your spam folder or junk folders. So please, something you can do right now today is go into your spam and junk folders, make sure that there's nothing already there from CMS that they might be waiting for, and make sure it's on your Safe Senders list. Once you're sure that you're not going to miss any of CMS's upcoming emails, here's a little more detail on what you can expect. So there's going to be preliminary selection letters that are going out, letting you know if you've gotten preliminary approval to participate. Again, this is just kind of an initial approval. Your final participation is still dependent on a program integrity screening, attribution to make sure your practice has 125 beneficiaries, and completing all these onboarding requirements that we're talking through. The letter is also going to contain a few other pieces of information, like your track assignment and your CTO partner if you've chosen to partner with a CTO. Within 2 weeks of getting that letter, there's also going to be a packet of forms that you'll need to return to CMS, again, within a 2-week time frame. The 588 form is for payment setup, and we're going to talk through that in a lot of detail in the next slide. But there's also 2 other very quick, easy checkbox forms that you'll need to return. So if you're partnering with a CTO, you'll need to select your CTO payment option. So just as a reminder, if you as the practice are providing the lead care manager, you'll be able to keep 70% of the care management fees and share 30% with your CTO. And if your CTO is going to provide the lead care manager, then you'll share those fees 50-50. So there's just a quick option 1, option 2 checkbox form that you'll need to send back to CMS to indicate your CTO option. And for track 2 practices, you'll also need to fill out a form for your CPCP payments. And that's just to indicate what percentage of your payments are going to be fee-for-service and what percentage are capitation. Very quickly skipping ahead into December, there's going to be a second package of materials that will have some additional steps for you to complete. So just to give you a very quick heads up on what those are going to be, there's 2 portals that you'll need to register for. The EPI portal, which is a system that CMS uses to process data use agreements, and also the EIDM accounts, which will give you access to the main primary care program portal come January. There's also a data worksheet that you'll return with your participation agreement to CMS and the CTO practice arrangements. So again, all of these will need to be turned in before the end of the year. So now let's go ahead and switch over to the 588 form, which is the main thing that you should be focusing on for the next week or 2. You can go ahead and get started on this since it'll take a while to set up payment. And I'll actually pull up the form in just a second and talk through a couple of highlights. But first, I just want to go through the steps that you need to complete in order to get this form submitted. So you'll need to download the form, print out a physical paper copy, and then fill it out. To fill it out, you need your legal practice name, address, and then some really important information like your banking account numbers and your tax ID numbers. For obvious reasons, it's really important that those numbers are accurate, so please make sure you do extra double checks on everything. Also on the form, there's some empty white blank space in the top right-hand corner of the form where we'll need you to write in a few extra pieces of information. One of those is your profit status, so whether you're for-profit or nonprofit, you can write P or NP for nonprofit. Also just handwrite MDPCP in the top right-hand corner so the people processing the form know that it goes with this program. And then finally, your application ID number. And that's very important for CMS to match up your form with your application and make sure everything is linked up correctly. Once you're done, you'll need to physically sign the form with a wet signature and then attach a voided check or a letter from your bank verifying your bank account information. And then you'll physically mail that package to CMS. We're asking that you use overnight mail with a tracking number. So after you put it in the mail, you can send a confirmation email to CMS letting them know that you've sent the form, this is the date you've sent the form, and here's its tracking number. So again, nothing gets lost and everything can be matched up. So I'm actually going to pause here and see if we can pull up the actual form and just talk through a couple of highlights. Okay, and zoom in here. All right. So this is a fairly straightforward form, but just a couple of things that we want to point out. At the very top, your reason for submission is going to be a new group enrollment, so check both these boxes. Over here in the top right-hand side, this is where we'll want you to write in that extra information like your application ID number and your profit status. Under account holder information in this section, this is all about your practice. So we'll want your legal business name, your practice address, ID number, and those should all be very straightforward. Some good news on this form is there's actually a few fields here that you can skip over. You don't need to put in a Medicare ID number or a health plan identifier, and you also don't need to list all of your provider NPIs. There's a lot of practices out there that have more than 3 providers in their practice, and it would get really complicated for us to request attachments with a long list of NPIs. So CMS is going to take care of all of that for you on the back end, but that's also why it's very important for you to put your application ID number in the top corner of the form. Right, so there's no reason to put in any NPI numbers on the form. And this last section on the first page is just all about your bank, so bank name, address. You'll need to give information for a checking account, so you'll need your routing number and your account number, but all straightforward information if you have it. And the second page is very, very simple, just a contact person and signature. Again, we need a physical wet signature on this, no electronic signatures, unfortunately. So it should be a fairly straightforward form, nothing too bad there, but we do want to make sure that you get everything in correctly and on time, because all your payments are going to be dependent on you getting this form submitted correctly. So with that, I think that's all we have in terms of presentation. So we'll turn it over to questions. If you do have a question, go ahead and type it in the questions section of your GoToWebinar control panel, and we will go ahead and read them off as they come in. We do have one question here that's fairly specific about an application. It looks like this person might have already received an email from CMS about some decisions. So we're going to go ahead and ask you to send that question to the CMS inbox. Again, the email is up on the screen here, just because we don't want to be too specific about your individual situation. We have another question here about payments. There are 3 different payment mechanisms in this program. Can we submit 3 different bank accounts for each payment type? If so, how would we do this?
So thank you for that question, and the answer that we believe to be true, and we've vetted this with CMMI, is that just one bank account per practice site should be submitted.
Another question, will there be a separate portal to make updates to providers as providers leave or join the practice?
So if there's changes in the practice roster, then there will be the ability for the practices to change their rosters within their portals. It's not a separate portal; it is part of the CMMI portal.
Next question, how may we appeal the PRAC decisions?
So again, the answer for anything that would have to do with appeals or questions there would go directly to the CMMI mailbox. That's not something that the state has any province over. Question, can we get a copy of the slides? And we will post the slides.
Yes, yep. We'll be sending them out shortly after this webinar, and the recording will also be posted on our website. That will probably take a few days, but keep an eye out for it. It will be posted on the site. Question about if we could repeat the deadline for practices to submit the 588 form.
So the deadline for the 588 forms is 2 weeks after they're received.
Companies with multiple practices, should page 1 of the 588 form show the individual practice address or the corporate main address?
I believe that should be the individual practice address, so there could be a differentiation of which practice that it relates to.
So you would need to submit, unfortunately, one per practice.
And just to segue off of that, if you've already submitted a 588 for a different program, you will need to resubmit a new form specific to the Maryland Primary Care Program. Our next question here is this the same bank account that we will receive fee-for-service reimbursement to, or will that go to the bank account tied to the TIN that is credentialed with Medicare?
So I believe that wherever your current fee-for-service payments will continue to go to that particular bank account. This would be for care management fees and performance-based incentive payments.
Next question is, on the form, the title is account holder name, and you said to list the practice name in that field. What if the practice is part of a larger group that is the holder of the bank account? I'm going to pull up the form again really quickly. Bear with us a second.
Yeah, I think that would be the practice name, not the parent organization. So if it was, the Main Street practice of Universal Healthcare, it would just list Main Street practice Universal Healthcare. Again, I think the important things here are going to be identifying what practice it is by your ID numbers and having the correct financial information.
Okay, our next question, have quality measures been released regarding the PBIPs?
They have not been released yet, but they will be with the participation agreements. I think we have a number of questions about appeals to track levels or other things. Again, I want to redirect those appropriately to the CMMI mailbox. I think that would be the place to get a definitive response on any issue related specifically to application responses.
Question is, you mentioned care management fees and PBIP going to this bank account submitted on the 588. Where will the CPCP payments go for Track 2 practices?
So I believe that the regular payments for the billed services that are reduced will go as usual, related to the claims, to whatever bank account those were previously directed to, and I anticipate that the prospective payment associated with that would go to the account that's listed on these current 588s. We will confirm that, and if you put it on next week, and if you'd like to send us an email, we'll send you a direct response to confirm that. That's my unsubstantiated response, but we'll confirm.
And remember that the comprehensive primary care payment, the CPCP, only applies to track 2 practices.
Right.
Yeah. Other question, does the wet signature on the Form 588 also apply to the CTO Form 588?
Yes, it applies similarly. Well, we're waiting for additional questions. I wanted to thank you for the questions that you've given. Again, we want to be able to provide as many timely and accurate responses as we can to these questions, and ask for your continued patience and indulgence as we go through the next 80 days or so of document production and review, evaluation, and your consideration whether this continues to be something that you want to proceed with. And I do want to point out again, as was pointed out before, that although this is a difficult process in some ways to go through with the number of documents, it is an important process to ensure that everyone in the program has access to the portals and that they get paid appropriately in timely fashion. And so it's one of those necessary things that we must do. And also that if they're not completed by January 1st, that the practices would not be able to participate in the first program year. There's no entry to the program at a later date until the subsequent program year.
I have one last question come in here about appeals. So please make sure that you send those questions to the CMS inbox. They will be the ones that are handling the applications and the decisions, so make sure that goes to their inbox and not the state inbox. We've had one more fairly lengthy question come in, so go ahead and read this off. Follow up on the account holder information question. We are a single TIN group with multiple practice locations. The overall medical group is the holder of the bank account with everyone under one TIN. Just want to be explicit about this question, making sure that we are completing it appropriately, understanding that we need to complete a form for all practices. In this case, the biller legal name would be the medical group and the provider NPI. Can you verify this?
Yeah, the answer is for first part of that is clearly that there needs to be a 588 for each of the practice sites. It can be the same bank account for all of those sites, but it should identify those sites. The should be identified by their location and by their practice application number. What further identification you do would really be up to you for your ease of identifying the practice.
Hang on just another minute to see if there's other questions. If you have any, please type them in now. So as we're wrapping up, I just want to point out that we have another one of these webinars scheduled next week. We actually have a whole series planned out every Thursday at 5 o'clock. Next week's topic should be care management, so we'll be talking about that aspect of care transformation, and we'll also give you another update on whatever administrative documents you need to be focused on for that week.
Great. Okay, we'll wait another minute, and then if there are no other questions, I want to thank everybody for their participation. Look forward to having a healthy discussion next week on care management and administrative details again, and point out that we are here to help us and assist in every way we can getting through the somewhat mundane but important process of document production, and look forward to January 1st to a real startup as we move through real practice transformation.
One last minute question here. Are notifications going out in batches? It sounds like some have already received notification, but we have not.
Let me answer that. I do understand from our colleagues at CMMI, because of the large number of documents that need to be sent out, there is some batching that is going on, and there may be even some duplication because of the numbers. So bear with them. They're making every effort to get these all out in a timely fashion, and I'm sure they will be within the next day or several days. So look forward to them, and make sure they're not going to your spam folder. Past that, everyone have a wonderful evening. Thank you all for your participation.